Hello, Ashenafi. You are still muted. Okay, now you can. Okay, great. Looking forward to collaborate with you. Jenna De Francisco is here in the room, and Amanda Frank is here. And the three of us with you will monitor and direct the regional meeting. This meeting is the AFRO and Euro regions.
Yadin, just to note, since we just started the session, it may not have been available for people to join until about 30 seconds ago. So you may, I know we're at the time we're supposed to start, but you may want to give people a few minutes to see if anyone else joins. Up to you though.
Okay. Ashenafi, are you able to hear Jenna?
Yes, I can hear.
Great, okay. Yeah, so the advice I just received is give it a couple minutes for people's ability to join from the lobby to the session.
Yeah, sorry about that. When Catherine asked me, I told her to wait, and I wasn't thinking that then people wouldn't be able to get in.
So what we did, we 2 weeks ago sent a series of questions and asked them to focus on that, plus any report on the state of the art of clinical engineering in their country. So it was the instruction to come. Mladen in South Africa is saying the internet is unstable due to strong wind. I think he needs to take
Yadin.
his physics course again. Those electrons are not subjected to motion.
Mario, we can hear you.
Yeah. Mladen is a friend. He takes my jokes.
Oh, Mladen.
Yeah.
Yadin, can you hear me? This is Mario.
Ah, hello, Mario. Of course. Of course.
Yes. How are you doing? I just pressed the meeting for AFRO, but I got this general one. How do you get the regional one?
You're in the AFRO regional.
This is AFRO/Euro regional.
Which one are you looking for?
Which one do
Okay,
you want to go
sorry.
to?
Because it says America's AFRO on the screen.
I don't think that we have all the regions showing this introductory slide. I don't think that we had time to prepare for single region.
Okay, so this is the AFRO Euro, yeah?
Yes, you're in the right place.
Okay.
You're on TED Talk now.
Look, I'm just. It's now 9 o'clock in the evening in Mozambique. I normally go to bed at 9, so I'm almost dropping dead. I don't think I can take it with the global meeting. Like,
Mario,
I'll fall asleep halfway through.
9:15, I'm a pumpkin.
Did you hear Jenna?
Yeah.
Okay.
Yeah.
I tell you, you know who is taking most notes here today? It's Krishnan. Krishnan walks from group to group and just taking notes. I'm telling you, based on what I see he's writing, IFMB in for a work camp.
Is Krishnan there?
Yes, in person.
Physically?
Yes. Yeah, tomorrow morning is part of the welcome address.
Mladen doesn't have mic access again. I'll see.
Sorry, Yadin, where are you physically at the moment?
I'm in
Orlando?
Washington, D.C.
Oh, okay,
at the AAMI headquarters.
okay.
And they gave us the conference rooms with the AV equipment, and Zoom is connecting us. And that's how we became virtual. So
Okay.
each of the region has a room just like the one I'm in, and the different region are going parallel in similar room. And Tom Judd is with the Americas, for example.
Okay.
I don't know if you had a chance to be this morning. We had the Global CE Summit where we looked at what are the biggest challenges and how can we address them. So that
Yes,
was
I would-
interesting.
Yep, that was good.
Hi, Emmanuel.
Okay, I think we can go ahead and start. The lobby directed people that are interested in the AFRO/Euro region to this conference room, and I'm happy you are here with us. Today we have an hour at least. We can go a little bit more to identify common challenges and action plans that we can be part of. Before we go into the actual discussion, I would like to recognize the organizers of the Congress, our IFMBE/Clinical Engineering Division, and the Global Clinical Engineering Alliance. AAMI is our host, and industry members such as R0, Zoom, Helium, and Schiller contributed financially to our ability to have this Congress over the next couple of days, and we appreciate that. My name is Yadin David. Jenna De Francisco and Amanda Frank are here, and we will, together with Ashenafi from Ethiopia, will monitor and mentor the discussion. Our aim to start with the African countries delivering report based on a series of questions that we ask them to focus on. And what we would like to see is the state of the clinical engineering in your country. What education and training opportunity you have, what kind of national organization, society, association you have in the field, how did COVID influence your career, and finally, we would like to hear a little bit of credit you can give yourself about things that you accomplished during COVID. We aim to have a series of this region meeting going on beyond today for the purpose of collecting the data, convert it to an evidence-based document, and connect with and present it to Ministry of Health. So that's the overall plan that we're seeing, and I'm ready to start. And if you are, let's go ahead. And first of all, Ashenafi, I would call on you and join me with any comments or the beginning of a report that you would like to deliver. Go ahead, Ashenafi.
Yeah, Dean, it looks like Ashenafi disappeared from the screen. Probably his connection went off.
Oh,
He was just there and it disappeared. So he'll be trying to connect soon.
Okay, I appreciate the update. I don't have specific order in mind, but I would like to go around the room and see who has a report that they can begin the description. I don't know, Mario, if you have specific state-of-the-art report or just discussion, but
no, with discussion, we're having a meeting tomorrow. We've been in the African region, we've been having regular meetings because within IFMB, there's the working group of African activities. Ashenafi will just join. But we have that working group. We've been meeting regularly. So we've been touching base with each other. But we're also tomorrow, just before this clinical engineering conference, that is Africa Health, where Mladen organized a module on clinical and biomedical engineering. And there'll be a debate where will be Mladen, myself, Ashenafi, Anna Worm, and Shona Mulali. And we'd be discussing clinical engineering, biomedical engineering in Africa. So we actually went through already quite a few things, but Ashenafi will talk about it. He's back in.
Beautiful. That's perfect timing.
Yep. Ashenafi, you there? I can see his name, but not the sound. But I mean,
you're in mute, Ashenafi. If you can unmute yourself, or do we want to have the monitors?
It disappeared again. It's probably having problems. But again, until it connects, is that we've been talking, all of us, and with the Ashenafi, myself, and Anna Worm has been working with Africa quite a lot. We all have, and with Mladen, we all have the very similar problems within the African region. Apart from the South Africa was probably worse hit by COVID, Mozambique very little, and some other countries not so much. But obviously overall, as someone said, COVID was actually a great opportunity for the world to realize that medical equipment does exist, and the hospitals cannot work without it. So for us it was a blessing in disguise, because it has actually put the clinical engineering and biomedical equipment right on top, which has been very important, because from now on, people look at all our community and the biomedical equipment as in a very different way, which is extremely important, because they realize now that hospitals don't work just from medical doctors and drugs. They need a lot of other things to work. And that's one of the problems where we encounter in Africa, because a lot of the equipment has been designed for very rich countries with the high level equipment, difficult to maintain. And when you put it in countries with low resources, not only in terms of money, but in terms of proper training of everyone, then it becomes a complicated problem. And that's one of the things we're all worried about. It's first of all, education, try and get more people trained. And one of the things that we're really worried throughout Africa for clinical engineering is, like in Mozambique, there's in the Ministry of Health, there's a medical physicist. But when you talk about clinical engineering, no one really knows what clinical engineers are. There is someone in this Ministry of Health, Abubakar Sumalji, should be here, but he has been having problems connecting. That is actually considered a biomedical engineer, and he did train with Mladen Poluta in South Africa for a year. So he knows Mladen, but he doesn't really work in hospitals. He works in the Ministry of Health and does some help. The problem is trying to convince the government that biomedical engineers are not just technicians to repair equipment. In Mozambique, there's a school. They call the correct name is electromedicine technicians. So the electromedicine technician is someone who's not even a BSc, is a degree below a BSc, but then they do have a good training, but at the lower level. And we really need people at a higher level. But that's a problem in Mozambique because several countries, and Ashenafi will talk about it soon, several countries do have better training than Mozambique, and they more recognized, because as Ashenafi will say, they got a very good award and recognition from the Ministry of Health in Ethiopia from their work. But in many countries in Africa, clinical engineers and biomedical engineering, the Ministry of Health don't even know that they exist. And that's one of the things we really have to fight for, better recognition and better training. And that's one of the things the problem I've been having in Mozambique. And then try and start getting a local society. But we have to start a local society with the technicians to start with, and then get people trained to higher levels until we broaden the society and get it more comprehensive. And that's one of the things that we're having a problem, because for me, I've been working hired by a central hospital of Maputo as a clinical engineer and biomedical and medical physicist. But when I was hired, I said, look, I'm not just a medical physicist, I am a clinical engineer. And they had to put the name there, not really knowing what it was because they never heard of. But at least in the official books in Mozambique, they actually hired someone as a clinical engineer. But that's one thing we really have to do, is to get the Ministry of Health around Africa to recognize the profession, to recognize its importance, and to give some incorporate those people incorporate us in the official offices, so that we can actually be involved in many things that a clinical engineer it's useful. But Ashenafi was here, so I'll let him talk. Over.
I'm not sure if you can read the flip chart next to me. I'm trying to
capture very well, yes.
Few words of what you're saying. One that I did not put up is a comment you made that you need to start society with technician. Why you cannot start with engineers?
Because we don't have engineers. See, my reason is that there's two things. Either we wait until we get biomedical engineers fully trained university level, and but then will take years, or we can start at a lower level with what we have, because like Abubakar Samalji is a biomedical engineer. He was an electronical engineer that did some training with Mladen, but he doesn't have the official university title. Like I don't either, but like him, there's only one or two people, so you can't start a society with one or two people. You need to start at a lower level, get recognition, and then slowly build up. That's what I meant. And that's one thing that will happen in several places in Africa. Over.
Got it, yeah. So therefore, the most important stuff is get the education corrected. So you would have engineering education and then continuing education as far as training.
Definitely, yeah.
Okay. Okay. Ashenafi,
Yes.
don't touch the microphone anymore.
All right. Okay.
Go ahead, Ashenafi.
Okay.
Give us your report.
Okay. Thank you very much. If it's possible, I can share the recognition, if you can see it. I
Yeah.
wasn't able to share it earlier, but this was a recognition. It is just a recognition given to the society in recognition to the technical support in prevention and treatment of COVID-19 and the continued provision of essential health service, national health workforce recognition. It was given on the week of July in 2021. So having said this, I would like to welcome everybody, and I would like to say thank you very much for the organizers, for all of you who have been supporting us. And I think I want to mention a little thing about the common challenges that we have seen. We already knew we have problems with maintenance, clinical engineering, capacity building, training. This has been appreciated a lot of time. But what I want to stress is there are no societies or few societies in Africa. That's just, let me begin from Africa. Having less societies in Africa will not enable us to be very strong when it comes to challenging problems. And the problem that we have in Ethiopia, as well as in many African countries, is integration. There is no integration between health facilities. There is no integration between the higher level and the management level and the lower level. So this integration between facilities, health facilities, that means hospitals, to tackle the problem is one of the biggest challenges that we face. The other problem that we have is communication. The communication gap we have, it could be because of the language barrier, it could be because of the professional barrier, or it could be with different hierarchical challenges. So the communication gap that we have deters more problems on what's already existing. We have been raising concerns and challenges about maintenance, clinical engineering, capacity building, and a lot of things. But when it comes to communication, we don't have so many communications pertinent to challenging all those problems. So I think I will call up on most of you maybe to give us your thoughts on especially what are the roles of the clinical engineers pertinent to the CA activity in each country, and the success stories in your country, as well as the challenges, as well as the way forward, in addition to what Yadin has already said. Thank you very much. Mladen, Jana, Mario.
It looks like Yadin is having some problems.
Yeah, we
Ashenafi,
were trying to get the volume up in the room.
Make sure their volume is higher.
Sorry.
Yadin, just
Yeah.
a technical thing. Ashenafi did send a message to several people. There are 1, 2, 3, 4, 5, 6 attendees from Africa. But according to this, I'm not sure if they can speak freely because they have the mics muted. It would be very nice if they could talk as well. I'm not sure how to do it.
We did try to promote them all to panelists, but they will get a prompt and they have to accept it. So the people who are still attendees did not accept to become a panelist. So we can send that again and promote them, but they have to click yes when it's.
So can you hear me now?
I'll have Catherine send that.
There's a button say you could put allowed to talk.
Can
yeah.
Okay.
Some of these meetings are tough times for people in different places around the world. But Bangladesh
So how many people have the microphone open?
So it looks like, okay, so attendees are now accepting.
Okay,
There we go. So we should be good. So everyone who wants to should be able to.
Great. Because we have Emmanuel, Janku, so if they could say something, it would be great. As well.
okay,
And here I'll add the notes from Ashenafi.
great. So I see Mladen is muted. If an attendee wants to speak, please let us know so you can be promoted to panelist. So if you can type in the text message, the technical team will be able to promote you to a panelist. Maybe
Yeah,
we cannot make you engineer, but we can make you a panelist.
So in addition to what I've already said, what has been written, I think I have also suggested about there are almost lack of societies in Africa. We have lack of societies, professional societies, in order to challenge the problem. Professional societies, especially when it comes to clinical engineers. Thank you very much.
Great. I appreciate you are correcting us. Other online, like Mladen, I can see you unmuted.
Should we go ahead?
Please.
All right. Well, thank you for organizing this this meeting. As Mario said, 3 of us will be participating in the clinical engineering and biomedical engineering conference tomorrow as part of the Africa Health event, which was not held last year, and this year will be virtual for obvious reasons like this one. And they have some great discussion and some great outcomes. We're covering biomedical engineering, clinical engineering, health technology assessment, innovation, and then we've got an interesting panel discussion as well. And we'll feed back to you on that in due course. But I think in terms of the questions that were posed, so I mean, Ashenafi, spoke about national societies, and this is, I think, a structural weakness in Africa for a number of reasons. And so my question to this group is, yes, some countries have got a critical mass of practitioners that make it feasible to have a national society, but that does not mean that clinical engineering activities in those countries cannot be supported and in fact cannot grow. So I think we need to think about outside the box and not see as national society as the only option or the only model. And I think back to 1995 when the African Federation for Technology and Healthcare was actually launched and created. And it was a broad church, so it allowed for members from, essentially all healthcare workers and many different types of organizations. So maybe, that's something that we could explore as an African region, because as I said, we have a pre-existing model which was very successful while funding lasted. But unfortunately, when funding stopped and was being funded by the GTZ, the German Overseas Development Agency, those activities came to a halt. But it's got a great model, and in fact, some of the if you like, strategic directions of the GCEA you could say were borrowed from the African Federation for Technology and Healthcare. So that's the one point. The second point in terms of language, yes, that is a divide. So we've got a number of groups in the African region There's an HTM leaders group, of which also we are members, and a lot of French-speaking people and colleagues participate in that. And Mario said in one of our working group for African activities of the IFMBE, that there have been meetings where in fact there have been two separate meetings, one Anglophone and one Francophone. And that also, it's not insurmountable. In fact, that might be a positive way of driving the discussion forward so that language does not become a barrier, but in fact an enabler. I mean, Mario, I don't know if Portuguese-speaking countries also need to be considered in the same light. If you're thinking of the African region, we also have Arab-speaking countries, in the very north, but they probably fall under EMRO. So what I'm saying is that we need to, Africa, it's a huge continent, population of 1 billion people, many cultures, many languages, and perhaps models that work elsewhere don't work too well here. That said, I agree that capacity building is crucial, and so CD and GCA can play a very important role in that regard. And I think with events like this, that already is well on its way. In terms of Ministry of Health, as I mentioned earlier in the previous session, that we here in the Western Cape had a very good meeting with our national ministry colleagues this week, where they agreed with us that action and resourcing of certain key activities was required. And this included policy, it included looking at standardized medical device nomenclature, around integrated asset registers of public sector healthcare technology assets. It included maintenance management system, but last but not least, and perhaps most importantly, about capacity development for clinical engineering and health technology management practitioners. So I think there's great scope, both within the different regions, and that's another conversation we need to have. Is Africa too big to be considered as one region? Should we look at, say, Southern Africa, Central and Eastern, Western Africa, because that was a model that has been adopted by some organizations, and it actually links to economic blocks. So I'm just putting these thoughts on the table. And then the last comment I want to make in terms of collaborating with the World Health Organization, collaboration and leadership from the AFRO WHO region has always been weak because they too have been undercapacitated. And there hasn't been a point person that is uniquely focusing on health technology and medical devices, never mind, clinical engineering and health technology management. And yet the African region has got a crucial need for clinical engineering, for health technology management, and hospital engineering in particular, because these are the professionals, the healthcare workers, that will actually ensure that limited resources are used optimally, and that assets are maintained effectively and lifetimes extended, and that maintenance strategies that perhaps are unique to Africa can be developed. So it is almost like, a no-brainer, and yet there isn't that resourcing from the African region. The encouraging development this week, there was a webinar which I unfortunately was unable to participate in, but there was a webinar. I'm not sure Mario, Ashenafi, and the other colleagues in this call were able to participate, but looking at the importance of medical devices in the context of universal health coverage. So that is definitely a bandwagon that we must jump on. We must seize that opportunity and perhaps come up with, I don't know, a concept note, a proposal, something that can build on the WHA resolutions on health technology and health technology assessment linked to universal health coverage, that we in our countries can take to our ministries, so that our ministries can take to the WHO African region. Because in the past, WHO, AFRO have always complained that countries have gone over their head to WHO HQ, and likewise, they've complained that WHO HQ have gone over their head to countries. But that's understandable because there are some still happening or you know, at WHO AFRO level because of their own undercapacitation. So those are my thoughts for now. Thank you.
So, two questions that coming up is one is your suggestions that because of language barrier and the size of the continent, it kind of forcing us to look at the sub-regions within Africa that I know other sectors, finance and transportation and so on, are doing anyway. And that we need to look at the French-speaking, English-speaking, Portuguese, etc., and Arabic, as you mentioned, as regions. So, are you saying that if we would have an international organization with a single language, that the participation is going to be limited? And clinical engineers are not able to participate in the single cross-continent organization?
I'm saying that, sorry, go ahead.
I think there's some of the idea that have been raised with respect to language from the one I have raised is different one, because when I say communication, the communication view that I have raised is the communication between professionals to the other professionals, the communication between hospitals, health and health centers and health posts with the Ministry of Health, with the regulatory organization. There's a communication gap. That communication gap is not only on the language, it's on the professional language that we have been speaking. For example, the professionals working on regulatory organizations could be pharmacists. The professionals working on hospitals are clinical engineers. The professionals working in Ministry of Health are doctors. So you have different professionals that cannot speak the same language pertinent to clinical engineering. So this is a view that I've seen. But when it comes to the language barrier that Mladen has raised, I think we can take this regional meeting as an example. This regional meeting is mediated in English. So do we have many Francophone participants in this Congress? Do we have many Italian speaking participants in this Congress? Do we have many Spanish speaking participants in this Congress? We can have people from there, but there is speaking English language. So language barrier is a key for us, but when it comes to HTM leaders and WGAA, I think these are two different things which have been raised. I don't know if we have to discuss it. They are not different, but they are collaborative. They are an integrated groups that I believe that can work together rather than being separated. And pertinent to the lack of societies, I think I strongly disagree with what Mladen has raised. We can have different highly skilled professionals in different countries, but having societies in that country will help us to strengthen the clinical engineering and the professional capability rather than weakens it. So having societies in the country is something that WHO encourage, IFMB encourage, even the GCAA encourage. So I think I strongly disagree with what Mladen has said. We need to have societies, and having a lack of societies weakens the recognition pertinent to the clinical engineers, I believe. Thank you very much.
So you think that the model of AHTF can work?
What does AHTF stands for?
The African Health Technology Forum. Mladen, what do you mean by that?
You broke up there, Yadin, but AFTH stood for African Federation for Technology in Healthcare.
African Federation for Technology in Healthcare.
For technology in healthcare.
Yeah, we're saying the same thing. So I'm trying to ask Ashenafi if this model.
But I would like, yeah, I would like, other colleagues who now have got the ability to speak. I would very much like to hear from other colleagues as well, because we don't hear from them very often. So I think this is the opportunity to share their view. And I think we've stated some views here. So my suggestion would be, sorry, I'm not the moderator, but my suggestion is let's get inputs from some of the other colleagues.
I totally agree with you, Mladen. We'd like to hear Emmanuel and Lionel here. At least they can speak, please.
Emmanuel, did you accept?
Oh, Lionel is here. I can see him. Let him talk.
Good evening to everyone.
Okay.
Yeah, I will try to give my own point of view about how the situation in Cameroon is. Well, in Cameroon, I can see the aspect of clinical engineering and biomedical engineering is it's a bit compromised because of certain challenges faced on the ground. So first of all, there is this aspect where clinical engineers and biomedical engineers are poorly paid, so they focus more on running after finances to earn a living. So this scares them. So at the end of the day, they have little time to spend for associative activities. So if we have to do anything concerning promoting associative activities, developing of competencies through, for instance, such initiatives, I think we have to also work hand in glove with our states, with our government, in order to raise the living standard or the pay package of engineers or biomedical technicians on the field. Another aspect is the issue where hospital facilities are poorly equipped. So at the end of the day, these technicians and engineers, they have very little to do in the hospital. So at the end of the day, they find themselves in the street doing one thing or the other in order to keep themselves busy. So when we organize such conferences, they have very little material to put on the table. They have very little material, very little experience to share. So they pay very little attention to associations, they pay very little attention to sharing of knowledge and to involve themselves in developing the aspect of clinical engineering in Africa. So I think as a group, we have to also brainstorm on how we can do to encourage our fellow colleagues encourage them to take this as a challenge, not to first of all focus on the financial aspect. It's true, they need a minimum in order to sustain themselves, to pay, for instance, their houses, in order to pay clothing. But then, I think as a young technician, as a young engineer, gaining access to experience should be the first. So in Cameroon, I think it's a peculiar country where things are not like in other nations. I don't know how it is in others, but here there's a lot of, the atmosphere is a bit, for me, I perceive it as a bit dark because people don't really have that willingness to sacrifice. People don't have that willingness to forego certain privileges. So at the end of the day, you see, people are unpredictable. They are some sort of unpredictable. You don't know if they will buy your idea or not. You cannot go into the mindset of individuals to understand why are they not taking part. For instance, the organization of this conference, I started telling several colleagues to take part in this activity, but to my greatest surprise, I don't think any of them even submitted an abstract for presentation. So at the end of the day, you see, you lobby people for reasons which we are not supposed to. This is a forum where people have to gain knowledge. We have to share experience. We have to know what is going on in other parts of the continent. But then why is it that our fellow colleagues are not encouraged, are not motivated? That is the first challenge which I have in Cameroon. So I must first of all answer this question, break this barrier before even talking about the sustainability of the association. There is an association in Cameroon for biomedical engineering, but then I think the activities are not frequent. So because of all the above mentioned reasons. So I have a big challenge. I'm still brainstorming. I'm still talking with other guys, colleagues to understand how we can foster, how we can promote this discipline in Cameroon and in Africa as a whole. That's what I can say.
I guess, I'm sorry, just a quick comment. I think one of the big problems around this is try and find in each country a champion to further the cause. It's not easy because it needs a lot of effort from yourself, and you have, as you say, you have your work to do as well. But in order to fight for the clinical engineering, biomedical engineering within the country, you need visibility and you need someone to talk to the Ministry of Health. If the Ministry of Health somehow doesn't approve and doesn't accept it, you find the fight is very difficult. So as Mladen said, there's a problem with the WHO. WHO African office should have a lot more influence within the country offices within Africa to talk to WHO country offices and recommend them locally to promote clinical engineering, biomedical engineering, and the importance of medical devices. Because if you get pressure into the Ministry of Health from WHO country offices, it'll be much easier than for people within the countries to at least approach the Ministry of Health because someone higher up has already talked to them. I don't know, Mladen, what do you think, how we can go through this to try and get Adriana is doing a fantastic job, but then the people after below at the regional, like the African office, there's a few people that are involved that have to make sure that they really fight for this as well. And then they talk to the country offices, because in that way, they will also avoid this problem of going from the country directly to headquarters, which can be a problem. But once you have that, then you need champions in each country. Someone has to suffer a little to try and fight for this cause. And then get together. But as you're saying, what Mladen was saying, if you don't have the enough critical mass of just maintenance engineers or clinical engineers, try and get together with a bigger group, a bigger federation, and get them all together with similar interests to try and promote things that are not just medical within the healthcare facilities, the hospitals, and support everyone and get everything forward. But it's just a thought. Over.
Waiting to other comments.
I think in Cameroon, okay, Emmanuel
Yeah.
can go on.
Go ahead.
Yes.
No, please.
Hello. Yes.
Yes.
Good afternoon to everybody. Sorry, I'm facing some technical issue with internet here. I'm currently in Port-au-Prince, Haiti. One of the challenge. So I will speak for partly for Cameroon. So one of the challenges that I've noticed in some years of practice in Cameroon is the unawareness of the medical staff in general about what is a clinical engineer. There is simply a very poor culture of what is the role, what is the professional figure that is called clinical engineer. And in the ministry, there is already a kind of recognition, because every year there is this recruitment of biomedical technician, biomedical engineer for the hospitals. There are several schools training the technicians in Cameroon and engineer even. But there is a problem of quality of the training versus the need of the market, and the unawareness of the professional, medical professional about what is a clinical or biomedical technician or engineer. When you go to hospitals or any other kind of health facility, you will find out that pharmacists, nurses, or medical doctor are simply not aware of what is a clinical engineer. And for them, a clinical engineer is just somebody who is there maybe to repair a fault or an equipment when there is a fault or a failure, and that's all. Which means that at the ministry level, we had several cases during the last year of lab technician. So lab technician who have been recruited as biomedical technician for the hospitals. So we have the school training, but in the hospitals, the title of clinical engineer or biomedical engineer is not equal to the competence. You will find people that have been trained as lab science technician, which are employed as clinical or biomedical technician. You will find some that have been trained in schools, but the level of the training or the quality of the training is questionable. And so we have those problems. One thing that I think is important to mention is also the lack of vision. We have a certain quantity, a certain mass of, let's say, biomedical technician, biomedical engineer, biomedical engineering professionals, but there is a kind of lack of vision. On that point, I will join Lionel. People are more interested in some specific type of activities, which are not, let's put it in a nice way, which are not the best for promoting the profession. So those are the few points that I wanted to mention. Here, there are some, well, as we are just discussing this, on this point, I will join Mladen on the fact that having an association or a society is not the only way of creating awareness about what is our profession, what is our role in the healthcare system. There are initiatives, for example, here in Haiti, where some technicians goes and asks to medical school to present what is their profession in secondary school. So there is this kind of promotion of our work, and I think that this is something that could be applicable to our country, to our context. Thank you.
Are there college level training?
Yes, absolutely.
Okay.
Yadin, could I come in?
Please.
So to go back to I mean, I think Emmanuel's comments were great. To go back to Mario's comments about WHO, you know, and I think a situation that I think is widely shared, but there is new leadership at the WHO AFRO office, number one. And what I'd like to say is that one of my hats is that I've renewed my alliance with the University of Pretoria, where I previously had a part-time appointment. Previously with the Graduate School of Technology Management, we can also become a strategic partner for GCEA, because they've got some of the, I would say world leaders, but really some of the top people in the areas of project management, asset management, maintenance management, innovation within that school. But now I've reconnected with the health sciences faculty, and specifically the Department of Public Health Medicine. And they're very well connected to health leaders, health managers at very high level, both within South Africa, but also within the African region. So I've already planted the seed, if you like, and asked them for their thoughts on how they could help us, assist us, facilitate, if you like, putting the clinical engineering, even biomedical engineering and health technology management issues on the table at WHO AFRO, so that those get supported. And again, I come back, you know, to my point about universal health coverage. If we say, you know, we think clinical engineering is important, therefore you should support us, chances are nothing's going to happen. But if we can show our value in realizing universal health coverage and take the initiative in showing how that can be done. And the importance of clinical engineering and health technology management in achieving, those goals that are clearly stated by WHO AFRO, then I think, we've got a much better chance of being taken seriously and getting support. Thanks.
So you are using words that have significant importance, like value and demonstrating value. Why can't we publish more manuscript, and therefore we will have evidence to show Ministry of Health? What do you mean by value added? Do we have examples of manuscripts that were published by clinical engineers about added value delivered through services? As editor of the Global Clinical Engineering Journal, I tried to solicit and got, I believe, from Kenya and from Benin, papers as well as a description of how do you maintain hospital in conflict impacted region, but it was not sufficiently quantifiable to show value. It was more of a description of a situation. Do you think we can make an effort to solicit and publish manuscripts in journals? I would be happy to support such effort during my management period of the Journal of Clinical Engineering, but I don't see submission on that.
Yadin, I'm sorry, just trying to answer. I'm sorry to being cynical on this, but for us, I think the manuscript is really important, but knowing some of the Ministry of Health, are you sure they're going to read them? Are you sure they're going to look at those manuscripts? That is my problem.
And it's a fair challenge. I can accept that, Mario. And if I go and knock on the door of a stakeholder at the ministry, and I would have an opportunity to orally argue, I might have a bigger impact if I leave a document on the table, even if they don't read it. At least they would have harder time to ignore me.
Point taken, yes.
Okay. I'll tell
You're
Broadway
right.
that they overlooked your talent. Okay.
I'm trying to get Sam into the meeting, Yadin. He's having difficulties joining or finding where to join. But just to comment on that, I'll put it in the chat because I was losing connectivity.
Okay.
I think publishing can certainly help, but I think a well-crafted policy brief will have much greater impact. We can, of course, reference publications, but just putting a publication on the table may create some awareness. But again, you're leaving it up to that individual to connect the dots and make the link. And try and see how this can be of value. Whereas if there's a well-crafted policy brief that clearly shows value, connects the dots, almost like a WHA resolution says, this is what's expected of member states, this is what WHO will do. In the same way, this is what is expected of you, you know, Mr. or Mrs. Minister or WHO AFRO region, this is what's expected of you, given what WHO at the World Health Assembly has undertaken to do. And then this is what we as member states, this is what we as professionals can do. That's just my view. But we haven't heard, again, I'd love to hear, I don't know how much time you've got, but I'd love to hear some of the other colleagues also.
Absolutely. Let's go around the room and see who.
So can I come in, Yadin?
Please.
Yeah, I think I just want to raise on issues pertinent to clinical engineers in innovation. We have discussed about clinical engineers in Ministry of Health's role in education, but I think we had experience at the Ministry of Innovation and Technology here in Ethiopia, where different innovators have been highly involved in redesigning ventilators, redesigning PPE devices, and they have been highly involved even in developing hand washing machines. Like clinical engineers in innovations is something that we need to really focus on, something that we have to encourage maybe in the future. We know what we have been doing in the health sector, but I believe we have to also focus on innovation and education. Maybe we can also raise it in the publication that we have been discussing. Thank you very much.
Would you say this is exceptional in Ethiopia to have an office for technology innovation, or it's across the continent?
No, we have it here in Ethiopia. There is a ministry, but by itself, it's a big organization, Minister of Innovation and Technology, one minister like Minister of Health. So it's not only having a ministry, but it could be a team, or it could be a department, or a group of different organizations. But I think the focus is just having innovation, involving clinical engineers in innovation. So we have seen it in when it comes to COVID. You know, when COVID arises, you know, we have seen too many innovations from the local materials, from the local setting. So that's a different view that we can see in the future pertinent to clinical engineers. Thank you very much.
So my room count is showing 13 individuals. I understand some have a microphone problem. Some did not accept the promotion to be a panelist and be able to speak. But I wonder if there are other voices that I would like to call on and see if they can join in the discussion. Thank you for sending Sam the link. Hopefully he will be able to reconnect.
Yeah, Dean, we did have a message from Martin, and I'm not sure where he's from. He said that he agreed with everyone and that even he may be from Ghana, even maintaining a central website and education resources would be of benefit. And this was when Ashenafi and others were talking about sharing kind of and standardization. He says, I'm working with the Ghana Health Services and Ghana Medical Health currently, and we've recorded a number of these training videos that may be of interest to the African community.
That would be a great resource if it can be shared. I don't see why it's not being shared. If it's up on the internet, Martin, is it not available, not accessible today outside Ghana, or what's the reason that people are not reaching out to it?
Actually, on the attendees, Martin is allowed to speak.
No, hello, it's Martin here. Can you actually hear me then?
Yes.
Yes.
Oh, that's great. No, I'm a clinical engineer on the west coast of Canada, working with CMBES, and I've just been listening in on the conversation about communication within the African countries, and just wanted to, reflect. Part of the initial comments were talking about the need for education, and just wanted to make people aware of the work that we're doing with the Ghana Health Services, and in conjunction with Ghana Medical Help. And to answer Yadin's question, yes, the training videos are very much accessible on the Ghana Medical Help website. And I get it's part of this gets down to Ashenafi's comment about communication. And I was just suggesting, there might be an opportunity again. It's all about communication. Just having ideally a central website that people would be aware of these kind of resources that are out there. It is needing a bit of effort for someone to maintain, that website. And I was just, again,
So Martin, we have
asking about the African Federation for Technology and Healthcare as that, potential.
We have gathered together some technical training that are non-commercial and addressing functionality of various instruments. And with Toby Clark and Riyadh working together, and Stefano from Italy, we created and review a library and provided that to WHO, to Adriana, and that is going into their website. In addition, the Global Clinical Engineering Alliance, in their website, we are building up a library of resources, and training is one of them that will be archived, available free to the world. The Global Clinical Engineering Alliance will have an annual event following this session, and that some of those activities will be described. But I think that your comment about what Eastern Canada is contributing to the effort in Ghana will be great if you can add the website on the chat.
Okay, give me a minute.
Okay. We're coming towards the end of the session. My apology for communication challenges that we had, but nevertheless, we're able to get some very interesting points across. I took some notes. The other moderator in the room, Amanda and Jenna, are helping me to capture those. And what it seemed like that we might be able to come up with some challenges that you can choose to agree or suggest that are not that important at this point. But what I learned today from this discussion, that we have a very large continent with variety of cultural and linguistic barriers that we need to consider. If we want to move ahead, we might be able to better achieve our goals and have more impactful deliveries if it will be language specific. Ashenafi thought that we might be able to be more globally than that and move ahead with English as a common language. I would love to be educated about that more and hear from you if that's reasonable expectation. We also learn about the lack of education opportunities and the lack of understanding. What is the scope of competency and the scope of practice that clinical engineers have as they try to get Ministry of Health and hospital position open up, and lack of understanding there make the hospitals hire other stakeholders, other individuals with variety of other training, not in clinical engineering, to deal with technology, including technology management. One specific example was the lab technicians. We talked about the need to have evidence-based material presented to the stakeholders in the continent. We talked about manuscript, and better yet, we talked about well-crafted brief that says, here is a problem and here is a proposed solution. So that's, in addition, we heard about the combination of titles that exists, all the way from electromedical technicians to technician in general, but not clinical engineers. That title is not understood and therefore is not being sought by the hospitals. We need to find a way how to drive the dialogue with Ministry of Health further, and to see if some type of organized activity can be directed towards the needs that are specific to the African continent. Some shared with us that there is a college training opportunity. Others suggested that there are none. So I would like to stand corrected, or let me be educated about that further. But as we come towards the end of the session, I would like quickly to hear from you. Are those topics the central issues, and do you believe they are orderly in a way that I described it? Let's go to Ashenafi, Mario, Mladen, if you have a calm wind afternoon or night and you still can be connected. Ashenafi?
Yes. Thank you very much. I agree in most of the ideas that have been raised. And what I love about this meeting is we have a different view of ideas. So, these are the areas where we can improve. Different ideas, different views will help us to widen our imagination and our thinking. And I love the way it's been viewed. And I totally agree with all of the issues that have been raised. And I believe these are the areas that we need to work on for this year. Thank you very much.
Thank you. Mladen? I don't want to lose you, so I'm calling on you, and then we'll go to Mario.
Mario, you're muted.
Mladen, you're supposed to talk.
Yeah,
But,
I was afraid to lose you, Mladen. So we call on you, and then we're going to Mario.
I said
okay.
Mladen drank too much coffee at night, so his brain stopped.
No, I've got to stay awake for the founders session sometime after midnight.
Yeah, you do have a town hall meeting. Absolutely.
Yeah. So I agree with Ashenafi. This has been an incredibly valuable discussion. I'm sorry that more colleagues did not participate, and I'm sorry that some of the attendees could also not join as panelists. But I think for me the main point is that we need to put all our issues honestly on the table and our perspectives, and we don't have to agree on every point. I think it's important that we agree on the important points. And so I think, if we can take some important points on which we do agree out of this meeting, I think that'll already be a huge step forward. As I said, it might be a very good idea to actually have a follow-up, to take these issues and have a follow-up issue once we've had time to reflect on what was said on the main points and whatever. But as I said, I think we need to think outside the box. We mustn't try and emulate what other regions are doing, not that it's not good, but there might be solutions that might be more appropriate for our region. Thanks, Jadine. You've been a very good, excellent, in fact, moderator.
I love it, and nobody else can talk until I hear it again from Mladen. Mario, you're next.
Thank you very much, Jadine. I agree with Mladen. You're a great moderator, and the way you wrote everything down is great. It's all the main ideas which I really liked. One interesting point is that we've been discussing in this working group with Ashenafi Mladen and our George Boadu and the colleagues. But every time we talk, it comes that we never really exhaust all the ideas. New ideas come up, new thoughts appear. So it's always very useful to come to these discussions and start thinking afresh and get new ideas. So I agree with you in most things you have. Going at one problem that I didn't comment about, Africa is really, really big. I remember a colleague of ours, Bafambai Bandika saying, right, I'm going next to you to Tanzania so I can go and visit you. And I say, you're joking. The distance between Maputo, the capital, to the capital of Tanzania, Dodoma, which is the country next door, is the same distance as from Lisbon to Berlin. And I said, what? Well, that's the size of Africa. People don't really know. So not only the country, the continent is really big, but that problem, we actually faced very seriously that problem of people who speak French, they don't want to speak English at all. We've had this problem several times. I'm working on several groups with WHO as well. And we have different meetings, one for French speaking and the other for English speaking, because the French speaking people refuse to speak English. And that is a big problem. Ashenafi knows that within the African group, they mutually exclusive in some way, which is crazy. And if you come to these meetings that we have now, we're all speaking in English. And if you refuse to speak in English, then you stay away. You don't come to these meetings. Nice. And how are we going to change this? It's complicated, but we really need to do that to incorporate things. Final point, because Africa is big, you can't just say, it's Africa, it's all the same thing. It's not. The problems on one side of the continent to the other can be quite different. And okay, they similar in the sense that the resources are poor and are scarce, but the actual structure, the way things work can be quite different. So you have to take that into account. Over.
Very good, very good.
To add one point on the language barrier.
Sure, yeah.
Yeah, just a couple of minutes. I think what Mario has raised is an important issue, but we had experience in 2018 when we hosted the first IFMB meetings in Addis Ababa, we just try to have the translator. Actually, it's just for the meeting, but if there is any means where we can have a translator applications when it is a virtual meeting, in actual meeting, we have a translator, it's obvious, but in virtual meeting, and we have to give awareness to all people that are coming from different regions, from Arabic, from Portuguese, from Francophone, from Anglophone, and from Swahili even. So, if they have this translator, they are happy to speak in their language. People love themselves. People love their language. People love to express themselves in their language. It's just about giving them more confidence to express their ideas than just give them an opportunity where they would lose confidence in expressing their own ideas. Some of the terms cannot be properly translated. For example, I speak Amharic. So I think in Amharic and I speak in English. It's a different way. Mario think in maybe in Portuguese and he speaks in English. And the French people, they think in French and they speak in English. So it's just a different way of expressing things. So let's express our ideas in the way we think. So if there is any means where we can have a translator, that would be helpful. Thank you very much.
Martin, any final comments?
No. Just reflecting Mario's comment that it's quite a large continent and obviously quite a diverse group, and I think there was also a suggestion of trying to perhaps create some divisions within the country, perhaps, and might be of benefit, but that's a future discussion. But I think continued discussions and support that we can provide with some of our programs that are a bit more progressive is areas that we can continue to help.
Great. Here in the room, the moderators have some comments as well. Jenna.
No, I mean, I just wanted to, it's so interesting listening to everyone and the uniqueness, and I'll speak a little louder, Mladen, I hear you, or I see you. I always appreciate, I think, how innovative you all are in the way that you approach such creative solutions to engineering problems in ways that, in maybe North America, we don't think of things that way. So you guys always are really ahead of the curve in many ways. And, I think the COVID challenges and things of that nature, you guys are much more flexible than many of us here in North America. So I just appreciate that. And hopefully I've captured some good notes for you guys to take back, and just thank you again.
Great. And sorry for calling you suddenly like that, but but I was taking advantage of you and taking the notes throughout the session, so we know we'll have good records. And we'll jump to Amanda.
Yeah, just thank you all for letting me be a part of this discussion. And I think what really struck me was the emphasis on the large geography and how it's not a one-size-fits-all approach, and how you can provide that and show that value and kind of embed it in these national health systems. So I think those are some really big buckets that, I think without hearing this discussion, you probably wouldn't think of these considerations, and then the language barrier and just understanding it doesn't have to be a one-size-fits-all box. And then also how can we change things and move forward so that we're showing, respect for different cultures and different ways to approach things, and being able to both think and speak in the same language. And how do we try to accommodate that? So I just think they were just some really wonderful points.
Great, thank you. Let's
Ashenafi also wanted to see if we could get a group picture.
turn our cameras on for a picture.
Okay, I'm gonna see if I can do this, so.
Okay, on a count of 3. Martin, you don't want to be in the picture.
Okay,
Ah,
1, 2, 3.
oh.
Also see if I can get a screenshot here.
Okay, screenshot. Ladina, sorry we didn't hear you, but hopefully we can grab you on the screenshot.
One more. Sorry, guys. All right, I tried my best. Hopefully it came out.
Okay, great. Thank you very much. We'll see you in less than 2 hours with Global Clinical Engineering Alliance annual event.
Okay, I hope you provide the coffee, Yadin, for us on this side.
We will do whatever it takes, Mario.
Thank you.
Okay.